Every drop matters. Every heartbeat matters. If blood is life matters.
Good morning. Hi, everyone. Good morning, good afternoon, and good evening, wherever you're joining us from. Could you drop in the chat? Could you drop in the chat? Good morning, good afternoon. Hello, can you hear me?
Very well.
Yeah, I can hear you.
Okay. Sorry about that. Good morning, good afternoon, good evening. Can you please drop in the chat where you're tuning in from? I love seeing our global community. I'm Fixin. I'm a nurse researcher, advocate for global policy, and I'm excited to say that I'm newly co-chairing the Bloodless Medicine and Surgery Society. Years ago, I was in the audience as an audience member, and bloodless medicine just made sense to me. The data and the practice aligned. And here I am now passionate about advancing it globally. And I would like to thank, first of all the volunteers that made this possible. Thank you for your dedication. And now, welcome to day 4 of Bloodless Medicine and Surgery Week 2026. Remember that May is Bloodless Medicine and Surgery Awareness Month. The Bloodless Medicine and Surgery Week, BMSW, is the month of May. It's meant to raise awareness about BMS as a superior form of healthcare, and it is organized by the Bloodless Medicine and Surgery Group in University of Calabar, Nigeria, in collaboration with Bloodless Medicine and Surgery Society, BMSS, the Society of Advancement of Patient Blood Management, SABM, and the Malaysian Society of Patient Blood Management, MyPBM. The theme of BMSW 2026 is Principles and Practice of Transfusion-Free Haematology. And now I am honored to introduce my co-moderator, Dr. Innocent Okwawo, the medical director at Safe Hands Hospital in Lagos, Nigeria.
Yeah, Sarah, thank you very much. I would also say welcome to today's session. And I just want to share a few housekeeping rules. First, we need to realize that all questions should be in the Q&A, question and answer section of the group. Want to minimize chats during the talk so as not to distract other streams on BMSS YouTube Zoom. You can see the Zoom link in the chat or type Bloodless Medicine and Surgery Society. Any other house. So that's just a few housekeeping rules. And then, Sarah, I leave it up to you now to introduce our speakers for the day.
So our keynote speaker would be Dr. Yi Yap, and the topic would be managing thalassemia major without blood transfusion. Dr. Yi Yap is a clinical hematologist who is working in Ampang Hospital, Ministry of Health, Malaysia. She did her fellowship in hemostasis and thrombosis in Australia. She acquired her FRC path in the UK, London, in 2022. She is also the president of the Malaysian Society of Patient Blood Management. She has been practicing patient blood management for many years with Dr. Jamila Satha, who is a pioneer of PBM of the country.
Thank you, Vixen. Right. And thank you, Nathaniel, for inviting me to present this quite a challenging topic. But I can share with you some of my experience managing thalassemia major for past 18 years. So let me advance my slides. Okay, this will be my outline. I would like to talk about the patient's psychosocial impact of thalassemia major, especially those transfusion-dependent thalassemia. One of my patients who has passed on. And secondly, I will touch on the novel therapies. And thirdly, of course, is genetic counseling in terms of prevention, which is very important, as well as screening. And last but not the least will be the gene therapy, now the new kids on the block, in order to cure all these thalassemia patients. Now, this is my case that I was talking about just now. Miss X, she's 25 years old, a beta thalassemia major that is transfusion dependent since 9 months old. She underwent the splenectomy at 19 years old. However, like last year, July 2025, she decided to estrange from her family, refusing further blood transfusion. For an excuse saying that she wants to move to KL, Kuala Lumpur, capital of Malaysia, to look for work. And she, in fact, from July last year onwards, she converted herself to be Jehovah's Witness. So what we actually try to do from my colleagues, Dr. Gilbert, thanks to him, who co-managing as well from the other side of Malaysia, which is Sabah, we call it North Borneo. So he has tried to give her erythropoiesis stimulating agent, giving her all this luspatercept as well. It started from July, August, and September. But you can see her response was actually quite poor. You can see the HB back in August when I just saw her in my clinic, it was 4.4. And that was her, and the HB slowly dropped to 3.4. And that's why she was on a wheelchair. We gave her hydroxyurea, we tried thalidomide. Despite all this, it's still not really working. And the HB was 2.2. And she was actually having, she was admitted to the ward. She's still very adamant, not wanting any transfusion. 5 days in the ward, worsening respiratory distress with cardiac failure. And family and friends also understood for the supportive care. They actually respected her wish and she passed on 3 months afterwards. Now, this is the photos that I actually took with her. Thanks to the hospital liaison committee of the Jehovah's Witness, yeah, that actually took care of her for the 3 months. I can tell you she was very happy without blood transfusion, in fact. And this was her as well. Lastly, when I saw her, she was still sitting on the chair, smiling at me, trying to convince me she made the right choice. Now, every time as a hematologist, because I knew that she's not responding to all the treatments, so I still counsel doing my duty for blood transfusion. So back in August, she gave me the first advance directive. And then when it's September, she gave me another advance directive when she was in a ward. So what she said, it's just a summary of it. I don't want to receive blood transfusion anymore, but it does not mean I don't value my life. I value my life so much by receiving alternative medicine without blood transfusion. I understand the risk I took based on my belief, but I understand that blood is pure to all people. that I'm very appreciative of all lives. I command that I'm not given blood transfusion, including red cells, white cells, platelets, or plasma in whatever situations. And I don't give anyone authority to override my decision, despite the disagreement from my family, relatives, and friends. Ladies and gentlemen, I have seen her a few times. I think she is very, very determined, and she's not really out of her mind. And that is really her advance directive that is translated, what she has written in Malay language. Now, these are the studies that related to health related quality of life in thalassemia. Yeah, you can see the one on your left that is descriptive statistic that they have done among the Jordanian thalassemia patients. You can see generally from general mental health, social functioning, physical functioning, bodily pain, vitality are all low. Same goes to the Iranian studies on your right. You can see the one from Ansari et al., the thalassemia major, that's on transfusion as well. They even compare it with the control group. You can see the quality of life scores that essentially is much lower. The physical, psychological, even social relationship environment, much more lower and is statistically significant from the p-value. So we all think that all these thalassemia major, when we give them transfusion, we treat them with iron chelation therapies, we give them all the folic acid, calcium, vitamin D, and there they go. But actually we neglected this essential part of them. This is our local studies, which has been done on your left, perception of healthy days and quality of life back in from our colleagues, Dr. Yo, as well as Dr. Goisim, one of our previous head of service, Haematology. So you can actually see the summary index on healthy days, which is 5.6 days over 30 days. That means that about 6 days they lost in a month. They're feeling unhealthy. And if you look at the domain of the physical health, psychological health, social relationship, and environmental health, they're all pretty low, 62, 64, 64, and 60.8. So you can see what sort of quality of life you're talking about. And the one on your right is the one I was sharing with you, the first case that Mr. X, that the state she came from, Sabah. You can see the quality of life among the pediatric patients with transfusion-dependent beta thalassemia major. The author actually concluded thalassemia negatively impacts patients' quality of life, especially the school functioning. And the study actually recommended considering quality of life as an important factor in the management of transfusion-dependent thalassemia patients, which includes providing out-of-hours transfusion thalassemia treatment service, implementing nurse-led programs that will offer social support. Yeah. So this is my case number 2. I have a 40 years old lady who was under our thalassemia clinic follow-up since the age of 25 in 2010. So her diagnosis was initially not certain. It was said to be thalassemia intermediate. Then at one point, I think 1991, people was actually diagnosing her as thalassemia trait at the age of 7. But if you look through her clinical manifestations, you see in 2010, she presented with heart failure, transfusing 3 units of PEC cells. Then she got acute calculus cholecystitis, transfusing 4 units of PEC cells. And then subsequently, you can see her HB is 8.4, platelets of 170, white cell of 8.4. Ferritin is actually high, 1,200, which is overload. And you look at her HB analysis, taken 2 months post-transfusion, actually showing HbF of about 97.5%, which is really, really high. And there's no adult hemoglobin there. And impression at the time someone was diagnosing as homozygous delta beta thalassemia, which I do not really agree. And it was subsequently, you can see she even demonstrating chest X-ray with heterogeneous shadowing, which is in proximal ribs on the right side, possibly extramedullary hematopoiesis. And the CT scan further confirm it, which this kind of clinical manifestation can actually tell you she's definitely not a thalassemia trait. She probably a thalassemia intermediate, but progressing into thalassemia major. So we actually advised her for regular transfusion. So she came for transfusing like every 3 to 4 months, but subsequently she defaulted. The reason being why she defaulted, each time she transfused, she would experience fever, chills, and rigors with transfusion reactions, and she has bilateral lower limb swelling. And actually, initially, also I didn't believe her when I put her in the ward and I saw her with my own eyes. She was really miserable with the transfusion. Yeah. At that time, she came back in 2016, HV6, we transfused her 1 unit packed cells. Now, this is a CT scan just to illustrate to you, to further confirm that the extramedullary hematopoiesis is pretty big, 6 times 3 on the right side, and the 4.7 on the left side at the arch of aorta in the spinal region. And you can see this CT scan together with the MRI. See these two mass here. So you can see it's very, very important to actually do transfusion in her regularly. And this is finally the diagnosis is established that I can confirm she's thalassemia major. You can see she has a beta DNA analysis that confirms she has compound heterozygous state of codon 4142 with the mutations of beta 0, Southeast Asia deletions identified. And alpha thalassemia is negative for her. There's no mutation detected. So the reason why she suffered from all these transfusion reactions, and of course, when we do all the red cells screening and the red cells antibody ident, we actually realize, apart from her phenotype, she's a positive R1 R1, Duffy A pos B neg, Lewis A neg and B pos, little s, and also the little k as well, JKA pos and B pos. She developed allo antibody that almost to like 4 allo antibodies, anti-big M, anti-big S, anti-big K, anti-big E. You can imagine how difficult to find the phenotype match bloods for her. Now this is again, of course, she keep on defaulting until she came back in 2024, where she was having runny nose, URTI, fever, again, HB 5.5, spleen 5-finger breath, liver 3-finger breath. Everyone will just put her into transfusion, yeah? Thalassemia automatically will be transfused. So she complained of fever again with the HB6 this time after given 2 units, yeah? You can see the white cell is actually becoming worse, 3.5, and the platelet dropping. That time when she just first came back to see us in July, it was normal. And then she has bilateral leg swelling with crepitations in the bases. And then further, someone transfused her when the HB dropped to 4.2, platelet further dropping to 17, white cell 4.2, and the Coombs test was positive with the IgG plus or minus, and total bilirubin is markedly raised, 186, mostly unconjugated, and the LDH is 1,000 over, which consistent with hyperhemolysis, in fact. The ferritin was 2,000 plus, she's overload, and the time they identified as alloantibody, NT, big M, and big S again. So with the 1 unit of red blood cell transfusion, this time I think she became even worse, that she was really, really sick in the ward, that even I did a Adams DS13 for her with a reduced like 33.5%, which is actually implying she's developing thrombomicroangiopathy. And the heptoglobin was not recordable. Luckily, the kidney was still all right. PT-ABTT you can see is marginally prolonged, and fibrinogen is actually borderline low. That is actually going into DIC a little bit. The dengue IgM, that time they think it was due to dengue, but after a while we realized this is just a bystander. Okay, this is her full blood picture, which is showing marked schistocytes, which we call fragments. Yeah. Now this, what we do, we actually didn't give her transfusion anymore. We gave her intravenous immunoglobulin. We give her erythropoietin stimulating agent, oral pred. We even metal pred her to pulse her. And in fact, the HB didn't improve that greatly, 4.1, and the platelet was still 111. Luckily, it responded. However, because she came in again becoming a bit not well, HB5, someone gave her blood. You can see the platelet drop again to 57, yeah? And the HB 4.6, platelet drop further, 25. So what I did in the end, I really didn't give her transfusion. I gave her luspatercept. And that's what happened to her with the HB 7.1 responding and slowly maintaining 9 and 8. And I just recently saw her and she's still doing well. Thank God for that. And this is without transfusion at all. Yeah? So what is thalassemia major? It is due to ineffective erythropoiesis, the defects in the erythropoiesis, as you can see, that leads to the accelerated differentiation and apoptosis of the erythroid precursors, resulting in the decreased red blood cells output. You can see this diagram here. The one on your left is normal erythropoiesis like you and me, where there is polychromatophilic cells, apoptosis and maturation arrest, where you can see that it subsequently undergo normal red cell circulations in the blood, whereas those with thalassemia, they get erythroid expansions, leading to peripheral hemolysis and eryptosis, they call it. Now, this is another discovery, the reason why luspatercept is actually working in her, because people found out there's aberrant SMAD2 and 3 signaling where they increased the aberrant TGF beta superfamily signaling via this SMAD2 and 3 pathway is component of the ineffective erythropoiesis and impaired erythroid maturations. So what happened is this TGF beta superfamily regulates the erythroid maturation during the late stage erythropoiesis. And this TGF beta superfamily ligands actually signal via the activin receptor 2B to trigger the SMAD2 and 3 signaling pathway. So this ligand binding triggers the phosphorylations of the SMAD2 and 3, enabling to form a heteromeric SMAD complex, where this SMAD complex will translocate to the nucleus and it modulates the transcription of the genes involved in the erythroid maturations. Now, that's how the luspatercept actually first in class as erythroid maturation agent that will decrease the SMAD2 and 3 signaling, enhancing the erythroid maturation in late stage erythropoiesis. Now, this is my case 3, thanks to Dr. Jamila. This actually gentleman was managed by her. It's a 38-year-old Chinese gentleman, E-beta thalassemia, transfusion dependent as well, 4 weekly. He suffered from iron overload, 1,100 microgram per liter. And his HB that time when he first saw us is about 10.7 on the 10th of April. So he was transfused 2 units of PEC cells. And luckily, he's a pharmacist where he got the support from the government to purchase the luspatercept. So we started him on 1 milligram per kilo, 50 milligrams. His HP, surprisingly, 1 week later, he repeated. He himself come and tell me, like 14.5, Dr. Mandy. Wow. And he was very excited that he does not need transfusion. Now, this is his molecular diagnosis. You can see he has no alpha thalassemia deletions at all. Whereas the beta one, you can see he shared a similarity like the case I presented just now, apart from the compound heterozygous state of the codon 26, which is HBE. The other one, codon 41, 42, is actually a beta 0 mutations, which consistent with the clinical phenotype that he's actually presenting to us. Now, this is his full blood count on the 30th. You can see 20 days later, he came to see me again, hoping he doesn't need transfusion. His HB was 12.5. So again, really, this is all patient's wish. He asked me not to transfuse. So I did not transfuse. So this is his palm. You can see the one with the black belt watch. The one on the white belt is me. So it's quite similar to what I am. Yeah. So I gave him luspatercept again, the 1 milligram per kilos, and repeated like 9 days later. He came to show me again, 11.9. Again, he asked me, can I don't transfuse? So I said, yes, why not? As long as you're feeling well. I say you feel extremely well. Now, there comes another question since he's a clinical pharmacist. So he recently married. This is his wife. So he wants a child. The wife has a hemoglobin of 12.5. And other than that, the MCV, MCH, MCV is actually 87. MCH is about 29. If you look carefully, the red blood cells is about 4.39. Usually the HB divided by 3 would be what the red blood cell would be. So it's not really that far off for his wife. And he did a HB analysis for the wife. The HbA is 97.3. The HbA2 is 2.7, which is normal range. And HbF is 0. Are you comfortable with just telling him he can go ahead? So don't forget, he's a E-beta thalassemia, yeah? And we all actually haven't further investigate this, his wife, because you all have to be aware, HbA2, if those with beta thal trait, for example, or even variant with the concurrent iron deficiency, they can have this kind of normal A2. Or whether she has concurrent alpha thalassemia, that also we haven't ruled out yet. So I would say that actually he needs to be further further investigated before I can actually counsel both of them. Yeah, in terms of genetic counseling for a thalassemia child, the possibility of getting a thalassemia child. Now, this is my case 4. I have a 19-year-old Chinese lady presented first pregnancy at 37 weeks with a fetus showing cardiomegaly. Yeah? Teenage pregnancy, they always present very late, no booking. And the partner was 18 years old, even younger, Chinese gentleman who was well. I think they both don't know what they're doing. And the detailed scan noted fetus had pericardial effusion, ascites with hepatomegaly. Sounds like hydrops fetalis, isn't it? Now, this is a full blood count of the couple. The HB was 14 for the male, MCV 18.3, MCH is 20.8. The white cell and platelets were normal, but you can look at the red blood cells. As I was mentioning just now, the HB divided by 3, isn't it? But this one is markedly raised, 6.74. On the other hand, for the female, HB 12.8, MCV low again, hypochromic microcytic, and you can see the red blood cell also markedly raised, 5.84. Now this is the HB analysis. The one on your left is a boy, it's a man. The one on your right is for the female. So both also normal. It didn't tell you much. In fact, what I want to highlight here, the HbA2 a bit on the low side, where alpha is not being ruled out. Again, HB analysis is not a sensitive method to rule out alpha thalassemia. Now this is a full blood count of the baby. HB 9.7, MCV 91, MCH 23, platelet 118. White cell is 4.9, but mind you, there's a lot of nucleated red, so 137, which you have to do a corrected white cell count. Red cell is about 4.2, which again appropriately raised compared to the HB. Now this is a baby. Unfortunately, the baby did not survive shortly after birth, and you can see there's ascites and it's swelling all over the body, and it's cyanosed, basically. And you can see the HB analysis on your right, which is run through with the capillary electrophoresis, which they fail to label with the zonations. The problem with this capillary electrophoresis, if they don't have adult hemoglobin as a reference, you cannot see the proper zonations. But what you can make out, you can see the highest peak here should be the HB bars, and subsequently followed by this epsilon, Galbers, as well as Portland. These are all like embryonic hemoglobin that he is not maturing yet or changing. And this is actually with the mixing of the donor red cells to have a zonations. You can see the zone 3, yeah? Essentially, we managed to label it, which like HB adult, 49 is from the donor. The BARTS is about 44.2. Again, thanks to Dr. Jamila, who diagnosed him as a HB BARTS hydrops fetalis. Now, this is his gel electrophoresis, which you can see the fast band of BARTS being here, and there's no other bands. And I can tell you the rest of these rows are actually belong to other patients which are normal. You can see this adult hemoglobin. And this is actually the E hemoglobin that is commonly seen in this part of the world in Malaysia. Now, this is my case 5. I have a 33 years old Chinese lady with HPH disease, which is an alpha thalassemia intermediate, non-transfusion dependent thalassemia. She just got married, and the husband did a HB analysis, which showed HbA about 93.1, A2 about 6.5, which is raised, and the HbF about 0.4%, and which was suggestive of beta thal trait. So what would you tell to the lady? She wants to get pregnant. So the good thing about co-inheritance of both alpha and beta thalassemia, it has the advantage of reduction of the alpha globin expression, which leads to a correction of the globin chain imbalance in the beta thalassemia. Therefore, if this lady asks me, I would tell her she would have an offspring with an improved phenotype. As you can see in this table, probably she would have a carrier, 50%. Another one would be a 50% having a thalassemia with alpha deletions, which essentially will have an improved phenotype. Okay, this is probably my last few slides before I end. So as I mentioned, I think those days when we were treating thalassemia, we used to advise them to go for allogenic stem cell transplant, where we have to look for a matched sibling donor. And I think haploidentical transplant is not really in favor anymore. And I think gene therapy should be the way forward, in my opinion. The reason being because now we have a lot of options be available, like gene additions, for example, the lentivirus, which is mostly available in China and India now, which is like 1/10 of the cost, is usually being done via transductions ex vivo with engineering after you actually collected the stem cells, giving them by GCSF as well as the plerixafor to the patients to mobilize the stem cells. And after that, we give them a conditioning like a busulfan or triosulfan to do an autologous stem cell transplant, infusing back the stem cell which has been transduced with the lentivirus. And essentially, it will help to induce an erythroid expansion with increasing the vector copy numbers and increasing the adult hemoglobin. And considering they will be cured, we're not needing further transfusion, especially in the thalassemia major. However, there's a concern regarding with this technology. That is why I think the bluebird technology in the past, it has been stopped because of the secondary malignancy as well as the insertional mutagenesis. Whereas on the other hand, now what is commonly recommended in the Western countries, gene editing, like in Canada, in Italy, in America, they will be using this CRISPR-Cas9, what they call it as clustered, regularly interspaced palindromic repeat, whereby the Cas9 act like a Caesar. They cut the segment of the genes and subsequently they will express. It's also being done with via the autologous stem cell transplant, similar concept like the gene additions. But however, the mechanism is slightly different, whereby it help to increase the fetal hemoglobin. And the problem with this gene editing is still very pricey now. I think it's 10 times more compared to what gene addition is. Right. Now, this is the diagram to just further illustrate to you how they do it with the lentivirus, where they actually transduce with this beta globin TH7Q to increase the adult hemoglobin. They even have this small hairpin. Down there, you can see they can actually use the BCL11A in order to induce the hemoglobin F by doing the lentivirus transduction. This is mostly done in sickle cell disorders. And again, I can tell you the CD34 hematopoietic stem cell that is being collected via apheresis purifications. The one on your right, on the other hand, I was mentioning just now the CRISPR-Cas9, that they were doing the cut. You can see like a Caesar in the erythroid specific BCL11A enhancer. And that's how they actually increase the fetal hemoglobin. And the take-home message, this is my last slide. Bloodless care is thalassemia is highly desirable. Prevention is better than cure. As you can see, the genetic counseling is very important. Like otherwise, it would be like a hybrid fetalis, like the case I presented. And last, of course, gene therapy is the way forward. And before I end, I would like to echo what Sirita was saying yesterday. Bloodless medicine is not a medical option. It is a human right issues and it's the dignity in care. Thank you.
Dr. Okwao, could you unmute, please?
Sorry about that. Thank you very much for your presentation. It's thoroughly enjoyed, and I expect a lot of questions from participants. But we'll go right into the next set of presenters. I have the honor to introduce two respectable women, Carrie and Jen. So I'll start by Carrie Marvel is a registered nurse and the nursing leader at Penn Medicine, University of Pennsylvania Health System, based in the greater Pennsylvania area. She brings extensive experience in oncology, nursing, clinical program leadership, and nursing administration with a strong focus on advancing high quality cancer care. In her current role as Associate Director of the Center for Transfusion-Free Medicine at the Pennsylvania Hospital, she develops and advocates outcomes of medical and surgical treatment without the use of blood products. Her co-presenter is Jennifer Polo, and is the nurse manager of the cellular therapy and transplant program and the Center of Transfusion-Free Medicine at the Pennsylvania Hospital. She provides leadership and operational oversight for transfusion-free medicine, anemia management, cellular therapy, and transplant services, supporting program growth, quality improvement, staff development, and interdisciplinary collaboration. Jen, as she's called, leads initiatives to expand transfusion-free care options for patients seeking bloodless medical and surgical treatment, including those pursuing transfusion-free cellular therapy and transplant. She partners closely with physician leaders, hospital stakeholders.
Hi. So I'm gonna,
We lost him.
yeah. So I'm gonna redo the introductions. So, hold on.
I'm going to share my slides just to make sure that everyone can see them, and while you're doing that, there we go.
Okay, so the next presentation will be done by Carrie Marville and Jennifer Polo. Carrie Marville, MSN, RN, NEBC, is a nursing leader at Penn Medicine, University of Pennsylvania Health System, based in the greater Pennsylvania, Philadelphia area. She brings extensive experience in oncology nursing, clinical program leadership, and nursing administration, with a strong focus on advancing high-quality cancer care. In her current role as Associate Director of the Center of Transfusion-Free Medicine at Pennsylvania Hospital, she develops and evaluates outcomes of medical surgical treatments without the use of blood products. So I'll read Jen's bio. So Jennifer Polo, BSN RN OCN, is the nurse manager of the Cellular Therapy and Transplant Program and the Center of Transfusion-Free Medicine at Pennsylvania Hospital. She provides leadership and operation oversight for transfusion-free medicine, anemia treatments, cellular therapy, and transplant services, supporting program growth, quality improvements, staff development, and interdisciplinary collaboration. Jennifer leads initiatives to expand transfusion-free care options for patients seeking bloodless medicine, medical, and surgical treatment, including those pursuing transfusion-free, cellular therapy, and transplant. She partners closely with physician leaders, hospital stakeholders, and the Jehovah's Witnesses community to advance safe, high-quality, bloodless care pathways. Previously, Jennifer served as a cellular therapy transplant coordinator and oncology nurse navigator, where she led quality improvement and patient education initiatives in oncology and transplant care. She is passionate about advancing bloodless medicine, improving complex care delivery systems, and enhancing outcomes for patients requiring specialized transfusion-free therapies. Go ahead.
Thank you so much. Thanks for the kind introduction. Just checking that you can see my slides. Okay,
Yes.
and I'll advance them for us. Thank you. So here are our financial disclosures. And today, Jen and I will be talking about our center's evidence-based approach to transfusion-free autologous stem cell transplant. We'll describe the clinical and logistical considerations of these therapies. And of course, with those, we'll discuss the risks and benefits. So the majority of those who do not accept blood products as part of their medical care are Jehovah's Witnesses, we know. We do have a small cohort of those who refuse for other reasons. And likely this audience is familiar with this graph of the Jehovah's Witness position on blood products and fractions. We know that they do not accept the 4 major blood components, and accepting of the derivatives of those components is a personal decision. And so I want to draw your attention to where the stem cells and most recently the engineered T cells sit under derivatives of white blood cells. And we come back to this picture often to really educate, especially our healthcare provider partners in this acceptance. And of note, as of March 2026, just recently, the Jehovah's Witness community may accept autologous red cell transfusions, and we're working on operationalizing that at our center. Our transfusion-free approach to auto transplant is based on these tenets of comprehensive patient blood management. So interdisciplinary blood conservation modalities, managing anemia, optimizing coagulation, and patient-centered decision-making. And specifically, we are optimizing blood counts before and during treatment. We follow special processing of stem cells to reduce plasma. We limit blood loss, and we focus on medication management for these patients. And we truly believe that this approach is what leads to our improved patient outcomes. This is a concise view of our approach, which is based on the publication of outcomes from our first 125 patients. I should mention that we collaborate closely with our program director, Dr. Patricia Ford, who's been a pioneer in this space for many, many years. And we adjust this protocol over the years according to learnings from our patients and their outcomes. And we'll describe each of these phases in more depth. And I will hand it over to Jen to start talking about pre-treatment and the mobilization, collection, and processing of cells.
Thanks, Carrie. So this all for us really starts with the pre-treatment, which often includes partnering very closely with our referring partners and oncologists, which is why we want to stress that for us, an early referral for transplant is very key because we can properly optimize these patients. So in the pre-treatment phase, we're very much focused on optimizing blood counts, identifying overall risk factors for anemia or bleeding, optimizing their hemoglobin with IV iron, folic acid, erythropoietin, vitamin B12. We found in our experience that we like to target a hemoglobin of 11. That's not always possible, but we'd like to get as close to that as possible. There is some clinical decision making depending on patient disease state and how soon a transplant is needed. Cessation of menses with injectable or oral contraceptives, and then again, GI prophylaxis and stool softeners to minimize any chance of bleeding in the GI tract. Next slide. We find it key to really work on identifying bleeding and anemia risk factors with patients with thorough H&P to understand, background of patient and other contributing factors. Um, and then most importantly is the medication reconciliation, working with patients, their current treating physicians, and our pharmacy partners to really go through and identify what patients are taking and medications to avoid. Particularly for us right now, and likely for many of you across the globe, the supplement market and things that patients may be taking on their own that they don't consider medications and don't think to report as part of their medical record, particularly key to pay attention to and ask. Many patients won't disclose unless you specifically ask them about all supplements, even those non-prescribed or over the counter. And as you can see from this list, there's quite a number of things that would be non-prescribed that could contribute to anemia or bleeding risk. Next slide. Again, we target a hemoglobin of 11. We run comprehensive iron studies on patients previously. We find IV iron and erythropoietin often given together. We can achieve a 1 gram increase in hemoglobin over a period of about 4 weeks. And then we also have a unique partnership as part of our program with our oncology registered dietitians. They are key, and as a standard part of our transplant process, we have them reach out to patients, partner with patients to do a comprehensive evaluation of their nutrition and recommendations of strategies and foods they can use to boost blood counts. And we do find that our patients are very appreciative of this, very open to this assessment, and it does also help us identify any possible risk factors for malnutrition when patients are going through the transplant process. Next slide. So during the mobilization, collection, and processing, we do mobilize with cytokines over using chemotherapy to minimize pre-transplant pancytopenia. We work closely with our third-party collection and processing providers. That partnership has really been key in working through what might not be a familiar process to them in terms of using no blood products. So we do our leukapheresis with a closed system filtering, and what's important and sometimes not thought about by those third-party collection partners is ensuring a machine is not primed with plasma, and that cells are processed for cryopreservation with albumin, normal saline, and the preservative DMSO, and that plasma is not used in that process. One key point that our nursing educators and any bedside nurses involved in the process really are key in educating the patients for is that patients will often see as you can see in the picture, that as cells are being collected, they have a blood tinged look in the bag, and this frequently causes alarm to the patients, and we need to reassure them that there are a small amount of red blood cells that may be collected in that process, but they don't survive the freezing process, and that's just a byproduct, and there is no live red blood cells that will be infused back in with the product. Next slide. After the apheresis process, we tend to have a fairly quick turnaround in terms of admitting patients for transplant, simply because many patients are coming from far distances, and the ability to be away from home, from a financial perspective, from a support perspective, is limited. So we will tend to turn around their transplant after collection fairly quickly. However, paying attention to the timing of transplant and allowing for recovery of blood counts after transplant is important. We do know in our experience that after one apheresis session, we expect about a 40 to 50% drop in platelets and about a half a gram decrease in patients' hemoglobin. Not related to bone marrow suppression, just simply the loss through the apheresis process. So we tend to 3 to 4 days after apheresis, bring a patient in and check a blood count to see how they're recovering. Again, we'd like to target them going into the transplant process with a hemoglobin as close to 11 as possible, and most importantly, want their platelets at about 100 or over. And sometimes that does require delaying the actual transplant process a day or two. So patients are taught that, that there's no hard and fast. We have an expectation of when they will go through the transplant process, but we do want to allow that recovery, especially in the platelets. Next slide. I think
Thanks,
I'll turn
Jen.
it back over to Carrie to talk about our conditioning and transplant now.
Great. So, like Jen said, once we are sure that the patient has met the threshold of platelets above 100 and hemoglobin as close to 11 as we can, we will admit them then for their transplant. We check a CBC that day or the day before admission. For conditioning treatment, we do administer standard doses of, for myeloma diagnoses, we use high-dose melphalan, and for lymphoma diagnoses, we use BCV. And just of note, we don't reduce these simply because of the transfusion-free status of our patients. Rather, we would dose reduce if they had reduced kidney function or other comorbidities. So important to note that they're still getting the maximum effect of their transplant. And in our cohort of recent patients, we observed a mean decrease in hemoglobin of about 4 grams. That is higher, around 4.6 for the BCV regimens. So the patient really has to be able to sustain a hemoglobin of around 6 to 7, given that decrease that we observe. And we know that we want to treat the patient's condition and not necessarily a number. And Dr. Ford has had some papers that really showed the tolerance of that anemia. Most recently, this is a poster that is quite tiny, but that we presented at ASH, displaying the tolerance of anemia and the safety profile if we start with a hemoglobin above 11. And a question that comes up with this is that no, we don't actually see any cardiac events or arrhythmias that are associated with hemoglobin in the sixes. That can, in the very early cohort of patients, before we knew everything that we knew, we would see some arrhythmias or cardiac events in profound anemia of hemoglobins below 5. Our approach includes pharmacologic and non-pharmacologic interventions while the patient is in the hospital. At our center, we do only perform inpatient transplant And there are some centers that are doing this outpatient. This approach includes weekly iron and epoetin while the patient is in the hospital. We use vitamin K and antifibrinolytics such as aminocaproic acid. And we give those standardly until the platelets are below 30,000. And then we will continue, or we start the aminocaproic acid when the platelets are below 30, and we increase that dose if there is active bleeding. As far as VTE prophylaxis, we are going to discontinue our pharmacologic intervention. So whether that is subcutaneous heparin or enoxaparin are usually our drugs of choice for this. We're going to stop that when the platelets fall below 50,000. And then we'll change to mechanical VTE prophylaxis. As Jen mentioned, to reduce the chance of rectal bleeding from straining, we will use GI prophylaxis and stool softeners. In our experience, a patient may have a very small hemorrhoid that once the platelets fall below 10,000, they can develop some oozing. And this is a very important part of our treatment protocol. And in our efforts to conserve blood and limit iatrogenic blood loss, I went ahead. Sorry about that. We have a few efforts that are really considered nursing interventions. So we rely so strongly on us as nurses to have an influence on the care of these patients in this way. So we start with limiting the amount and number of phlebotomies, really only ordering tests that you would act on. And here in the United States, sometimes they can get very order happy, and our labs have the ability to run any lab that you could possibly want, but really honing down to what would we act on and what is necessary. I'll drop down to considering pediatric tubes. Those will just obtain a smaller volume of blood for patients. But I always suggest to consult with the lab first. Personally, we tried to use this, but because we are an adult-only facility, our lab did not have the equipment to run pediatric tubes. So after many efforts to do this, they were just opening the tubes and pouring them into adult-sized tubes anyway. So see in your institution if that's something that's feasible. This patient population almost always experiences a neutropenic fever, for which we will do an extensive infectious disease workup, which includes usually 2 sets of blood cultures. And then if the patient is consistently febrile, we would be obtaining those blood cultures every 24 hours. In this population, and it's carried over into our standard patients, is that we're going to consult infectious disease for this true blood culture need. So we are not drawing the large containers of blood that are needed for those blood cultures every day. Rather, if the patient has persistent fevers, high fevers in the setting of full coverage with antibiotics, antifungals, etc. We also want to avoid central line wastage. We do use central lines, mainly PICC lines, for patients going through these treatments. And there are some products that can be used that limit the wasting of blood just to conserve every little bit. One key effort is in preventing bleeding, so fall prevention. This is a basic nursing intervention, and really patient education of informing them, don't get up without my support, especially with the diarrhea that can occur as a side effect of the conditioning treatment. Patients will have volume loss, become lightheaded, and it's really important that we prevent falls, thus preventing hematomas or bruising and injury. We know that especially during the time of their nadir, their oral and mucosal care is really important. Patients often develop oral mucositis, erosion of the oral cavity, and so good oral care is paramount in these patients. And of course, we want to prevent bleeding, so we tell them to avoid flossing, still do their oral care, but just with a soft toothbrush. And often some of the patients are experiencing hair thinning or loss, or full loss during this time. And we recommend, if they opt to cut their hair, to use an electric razor over a straight razor in this situation. We are still giving some injections. So part of our standard treatment is administering GCSF, or blood growth factors, to support those cell lines after their nadir. And so we can't avoid giving some injections, but it is really important for the nurse to provide firm pressure to injection sites to prevent hematomas. Dr. Ford always gives an anecdote about how a patient's hemoglobin just kept dropping and dropping, and there was no obvious source of bleeding, but then found that the injection site for the GCSF was in the thigh, and the patient had really lost a gram of hemoglobin, was bleeding into their thigh, and had a really large hematoma. So in our nursing education, we are we drive that home with them. And then, as always, just performing a very thorough bleeding assessment of all systems. And like I said, it's really our nursing colleagues in this space have a huge influence over the care of these patients. And then engraftment of the cell lines. What's interesting is that our Jehovah's Witness or transfusion-free population has really acted as a true control in this sense. And if you're familiar with the definitions of engraftment, we use the Center for International VMT registry to their definition of engraftment, which takes into account a washout period of 7 days after a patient's received a transfusion. So for our transfusion-free population, we are really seeing true engraftment, and that is happening at the same time as our non-Jehovah's Witness patients at around day 11 after transplant. And then platelets, we actually see, since they're not receiving platelet transfusions, we're seeing that engraftment happen even earlier than our non-Jehovah's Witness cohort. Here's another poster that we presented I think this might have been at SABM, but we showed that alternatives to platelet transfusions really support this therapeutic approach, and we did not see any significant difference in bleeding events between patients who do and do not accept blood products. This is a question that comes up with the patient's inability to accept a platelet transfusion in the setting of severe thrombocytopenia. However, we do have a protocol if the patients do have bleeding, and our goal here is always to enhance hemostasis. So in these patients, they will previously have been on aminocaproic acid or an antifibrinolytic. We'll increase that dose from 1 gram to 4 grams every 4 hours, and we'll continue that through discharge. Specifically, if the patient experiences any epistaxis or nasal bleeding, we will start vasoconstrictors. They used to do just nasal packing, but then found that every time that packing came out, the bleed would resume. So we consult with ear, nose, and throat about those patients, and have found that the local nasal vasoconstrictors, such as Afrin, are really effective in this case. Of course, they can only be used short term. And interestingly, we did see, if we think back to that graph of the accepted products and derivatives, our patients would consider cryoprecipitate. We make sure that that is in their advance directive and that they have selected that they would consider that. But if there is active bleeding, we could use that plasma derivative, which is really rich in fibrinogen, factor VIII. And so that is one tool that we have and have used successfully. Other options include DDAVP or Kcentra, which is a prothrombin complex concentrate. And this is really shows the importance of working with your pharmacy partners to stay aware of new uses or new products that are out there and their uses for this population. So in conclusion, we see that experienced centers can perform transfusion-free auto transplant safely without significant morbidity and mortality. And at our center, we are adapting this, the auto transplant approach and are using it for CAR T cell therapy. We have successfully administered about 15 CAR T treatments in transfusion-free population. And we're growing that body of work with a nice safety protocol or profile. And like I mentioned, with the transfusion-free population really serving as the control, we seek to challenge the current ASCO recommendations for prophylactic platelet transfusions to occur at platelet counts below 10,000, with the potential to lower this to 5,000 given the outcomes that we have seen in our program. And with that, I'd like to thank Dr. Patricia Ford, who has really led this effort and is mentoring Jen and I and others in this work and our cellular therapy and transplant program at the Abramson Cancer Center at Pennsylvania Hospital. I leave you with some contact information for our program if you'd like more information. And here are a few references that we referenced in our presentation. Thank you very much.
Thank you, Carrie and Jennifer. And I think today, this is Nurses Week, so happy Nurses Week. Thank you for your presentation. So our next presenter would be Professor Lalindra Gunaratna, and it would be on managing hematologic malignancies without transfusion. Professor Gunaratna is a hematologist at the Faculty of Medicine, University of Colombo, and the Director of Clinical Hematology and Bone Marrow Transplant Unit at Asiri Central Hospital, which houses Sri Lanka's first allogenic hematopoietic stem cell transplant center. He completed his hematology training in Sri Lanka and King's College Hospital, London, and holds FRC Path UK in hematology. His clinical and academic interests include hematology, bone marrow transplant, and acquired coagulopathies. A pioneer in advancing hematology services in Sri Lanka, Professor Gunaratna established the country's first flow cryometry laboratory for the diagnosis of hematological malignancies in 2009, significantly strengthening national diagnostic capacity. He has since contributed to expanding access to specialized diagnostic and transplant services for patients with blood disorders. Professor Gunaratna.
Thank you very much, Fixin. Are my slides visible?
Yes, they are.
Very well.
Thank you. Thank you very much for inviting me to this very interesting session. Listening to the previous speakers, I think I learned quite a bit And my topic is, of course, quite a challenging topic. And to start off with, we see that about 6.6% of total cancers, of all the cancers around the world, are hematological malignancies, and about 7.2% of total cancer-related deaths worldwide, as reported in 2022 by GloboCan. Now, when we look at this distribution of these cancers and deaths due to cancers, you can see that the countries which are sort of more developed, like like North America, Canada, Europe, and Australia, have higher numbers of malignancies, hematological malignancies, and the lifetime risk of developing one than in countries like where I come from, Sri Lanka, in the Indian subcontinent, and Africa, and so on. But we all know that there is an increasing trend with the incidence and prevalence of all cancers, including the hematological malignancies, increasing every year throughout the world, and therefore managing these patients, especially without blood transfusions or without transfusions, is quite a challenge. To start off with, let me just remind you of how these blood cancers arise. So we have the hematopoietic stem cell, and then this hematopoietic stem cell differentiates into either a lymphoid or a myeloid progenitor. And then in their immature state, we refer to these cells as blast cells when they come out into the peripheral blood. And if there is minimal differentiation and maturation, we would call them as acute leukemias, acute lymphoblastic and acute myeloid leukemias. As these cells mature and become the blood cells which we are familiar seeing in the peripheral blood, and then they acquire clonal sort of genetic mutations and so on, and they form clones, then they would be more mature cells, and then we would refer to them as lymphomas, either B or T cell lymphomas, where we would see patients having lymph nodes, enlarged lymph nodes, and in the case of the chronic myeloid leukemia and the myeloproliferative neoplasms. Now, the reason why I pointed this out at the beginning of my talk is that when we look at the hematological malignancies, their clinical effects and their presentation and their management are somewhat different, as we all are aware. And you can see the age-related or age-standardized rates of these malignancies are increasing, both their incidence, their prevalence, and the deaths due to that are increasing throughout the years. You can see that the non-Hodgkin lymphomas seem to be the most prevalent of the hematological malignancies. Now, if this is a photomicrograph of a bone marrow biopsy, and if you compare this on your left, the biopsy, the photograph on your left, you will see that the cellularity of this bone marrow is not very much, maybe about 40 or 50% cellularity, with a lot of fat spacers. When you compare that with the bone marrow biopsy on the right, you will see that the bone marrow biopsy on the right is full of cells. It's very cellular, leaving very little space for any of the normal bone marrow cells to act. And therefore, even at the start of the disease, when patients present to us, especially those with acute leukemias, you see that their bone marrows, unlike most other conditions, do not have space to produce normal hemopoiesis because it's stuffed with the immature cells. So therefore, in order, we were looking at various growth factors that are used to increase the hemoglobin, the white cells, the platelets, and so on. However, when there's no space for these to work, for the normal hematopoiesis to work, it becomes more challenging when we use these sort of stimulating agents to improve the hemoglobin or the white cells or the platelets in this cohort of patients. In addition to that, when treating them with chemotherapy, intensive chemotherapy, like in the case of acute leukemias, the chemotherapy not only suppresses the malignancy, but also the healthy hematopoietic cells. That's the reason why it is very challenging to try to manage these patients with minimal or no transfusion at all in these patients. Now, of course, there are concerns, even if patients who are happy to have transfusions, with giving increased transfusions in hematological malignancies. We know of all the complications of blood transfusions, and in addition, they can get long-term risks of alloimmunization, which can impact on hematopoietic stem cells, hematopoietic stem cell transplants, especially today in this day and age when haploidentical or mismatched donors are being used for transplant. The HLA disparity can cause problems in this. And of course, iron overload and transfusion-related immunomodulation or TRIM can all cause concern with increased transfusions in any case. So I'm just going to look at some of the PBM strategies that have been used or we use to restrict or to minimize the use of allogenic blood in patients with hematological malignancies. The first is something which is familiar to all of us, and that's the restrictive transfusion policy. Then minimizing iatrogenic blood loss. One of the previous speakers also alluded to that. And one of the main contributors to this can be drawing blood for diagnostic blood tests. And limiting that to the bare minimum is something that we should encourage and put it into protocols. As one of the previous speakers mentioned, using PD tubes together with consultation with the laboratories can also minimize this unnecessary wastage of blood. So, for example, in our patients with myeloma who undergo autologous transplants, we usually remove the central line after introducing the stem cells because and we just use a peripheral venous access, and this prevents or reduces the wastage of blood every time we use blood or withdraw blood from the central line. The next, of course, is correcting nutritional deficiencies, which is extremely important. However, sometimes it's very difficult when the patient presents in the acute state, like with an acute leukemia. We don't have time to correct those nutritional deficiencies at the time when we start them on treatment, and therefore it has to go hand in hand with the specific treatment that they get. So liaising with the nutrition team is of utmost importance in this cohort of patients. Managing coagulopathies, identifying and preventing bleeds, doing BAT tests or bleeding assessment tools when the patient comes in, and before we start treatment is also of great importance. Sometimes you can see in the sort of more elderly patient that the patient may be on antiplatelets, which don't have a strong indication for it. And therefore, that sort of patient we would counsel and try to stop or withhold the antiplatelet treatment. Then, of course, the ESAs, the erythropoietin and thrombopoietin stimulating agents, some of the more novel agents, which Dr. Mandy referred to, like luspatercept. And then, of course, with the invent of targeted therapies versus the standard chemotherapy, the need for transfusion products has got less now. So when you think about the restrictive transfusion policy, it is I think mandatory that such a policy is developed in your centers, and there have been quite a few systematic reviews where it shows that there is no difference in having a restrictive a restrictive hemoglobin of about 7 or in these patients, while we are reducing the RBC transfusions by about say 40 to 45% across a board of a broad range of clinical specialties. So there is no evidence to show that restricting transfusions or keeping them maintaining a lower hemoglobin can impact the 30-day mortality or morbidity. However, the evidence is not as strong for restrictive transfusion policies when it comes to cancers, hematological malignancies, and bone marrow failure syndromes. However, I think we need to assess each patient individually or independently and then decide how low we can go before we think or speak to the patient about having transfusions. Sometimes we can go to even less than 7, even to 6 in these patients if they are otherwise well, and especially if they have been having chronic anemia for a long time, and they're tolerating symptoms and symptoms of anemia, then we can push the limits even more. This is a publication from Vox Sanguinis, where, again, in a retrospective analysis of 352 patients with acute myeloid leukemia, the conclusion is that a more restrictive transfusion trigger does not affect important outcomes of these patients. So one of the most challenging group of patients to restrict these transfusions are patients who undergo allogeneic transplant and those with acute myeloid leukemia undergoing high-dose chemotherapy. Right, what about the nutritional deficiencies causing anemia? Now, this is a publication from the European Journal of Haematology this year, where it talks about a comprehensive review of the classical and emerging therapies. We heard about quite a few of them previously, but malignancy-associated anemias affects quite a significant number of cancer patients and patients undergoing chemotherapy. So again, it is multifactorial. It can be due to bleeding, due to the treatment, bone marrow infiltration. Functional iron deficiency is something of note which we need to consider, and liver dysfunction, kidney dysfunction, immune-mediated hemolysis, nutritional deficiencies from poor oral intake, and the place of iron, vitamin B12, and folate are of utmost importance. Again, here, I think one of the important things in our sort of practice is the use of herbal medicine and herbal teas and so on. So I know I saw in one of the previous presentations also that patients who are not really taking medicines, but medicinal products like, for example, garlic, again, is something which is very common in this part of the world where patients drink garlic juice, and this can affect the platelets, as we know. Another problem is that patients drink a lot of tea, and we know that when you have strong tea, especially with your meals, that it can block or obstruct the absorption or decrease the absorption of iron. And we've had patients with iron deficiency purely because of the fact that they're drinking lots of tea with every meal that they take over a long period of time. So these are also important things to ask the patient when you consult when the patient consults you, and a diagnosis of a hematological malignancy is made. Very recently, we had just a case I want to illustrate to you. A 67-year-old woman who presented to the general physician with lethargy, worsening of exercise tolerance, and a backache. And her hemoglobin was 6.8 grams per deciliter with hypochromic microcytic indices. and a very high ESR. During her workup, it was found that she had bone lesions and a high paraprotein in serum and a bone marrow biopsy of about 50% plasma cells. However, although we know that anemia is a common presentation or common at presentation in patients with multiple myeloma, which she also had a coexisting iron, a serious iron deficiency. So we gave her some IV iron, and at the time when we started her treatment for myeloma, her hemoglobin had gone up to about 9.5 grams per deciliter. So this is just a very simple day-to-day example of us, to be aware of these nutritional deficiencies which can coexist with other causes, the more sort of obvious causes, which can give rise to anemia or thrombocytopenia in patients. Preventing coagulopathies and bleeds is another important thing that we need to look at. Supportive care in this group of patients with treating infections early, using antifibrinolytics. We have tranexamic acid available to us both intravenously and orally. And then clinical vigilance, monitoring for early signs of bleeding, which can then, we can prevent bleeding without having to transfuse them. Other safety measures also mentioned previously are mouth care, which is extremely important in this cohort of patients because with the thrombocytopenia, the mucositis, which is caused by the treatment sometimes, and with superadded infections, they can have very sore mouths with bleeding. Then agents like non-steroidal anti-inflammatory drugs, which can cause gastric irritation and can alter platelet function, are also stopped even if they are on it. Now, it's interesting that this systematic review and meta-analysis of a randomized controlled trial with sequential analysis was published last year in the Journal of Thrombosis and Hemostasis, where these are in patients with hematological malignancies, where it was concluded that tranexamic acid did not provide sufficient benefits to justify its routine use for preventing bleeding in this patient population. So even though the evidence, and these are from systematic reviews, shows that they may not be of benefit, sometimes we have to resort to this in order to reduce or prevent the transfusion of blood products in this cohort of patients. The other thing, as we heard earlier, were about the erythropoietin stimulating agents in the management of cancer-associated anemia, ESAs, including biosimilars. And this is important because in our part of the world, we have a lot of biosimilars. So the ASCO and ASH have both said that ESAs, both alpha and beta epoetin, darbepoetin, and biosimilars of epoetin may be offered to patients with chemotherapy-associated anemia, which we do, especially in palliative care patients whom there's no curative intent. It is also very important that before we resort to ESAs, that we make sure that there are no other causes of anemia, especially that the patient is iron replete, because we know that if the patient has iron deficiency, or if the iron stores are not adequate, then the erythropoietin may not work properly. Again, when we administer high doses of erythropoietin up to about 60,000 units per week, then there is a risk of thromboembolism in these patients. So as we all are aware, thromboembolism is more common in patients with malignancies, and therefore we need to consider and do a risk assessment before we decide on how much of ESAs to use, the dose of ESA, and then we sometimes have to reduce the dose if there is a high risk of thromboembolism and we are unable to use prophylaxis to adequately counteract that. Another thing that we need to be aware of when we are giving ESAs is that we need to monitor the hemoglobin fairly carefully, because we have had instances where the hemoglobin can overshoot, and that too can cause problems. Now, if there is no increase in the hemoglobin in about 6 to 8 weeks with the maximum dose of ESAs, then continuing it is probably not sensible, because that will increase the risk of thrombosis only and not really do anything very much in this group of patients. Because as I mentioned earlier, sometimes the bone marrow or the factory in where the hemoglobin is made is not amenable for erythropoietin stimulating agents to work in this particular cohort of patients. What about management of thrombocytopenia? Again, in the use of thrombopoietin receptor agonists like L-Thrombopag and Romiplastin, there's evidence to show that this has a good benefit in patients with solid malignancies. However, in the case of, and I'm not going to go through this because Dr. Mandy has explained this to us. Oh, sorry, no, she said about the luspatercept. Yeah. So this is Romiplastin, which acts on the thrombopoietin receptor and facilitates or stimulates the function of this JAK-STAT pathway to produce platelets. So in the case of hematological malignancies like acute leukemias and myelodysplastic syndrome, the use of thrombopoietin receptor agonists like L-Thrombopag and Romiplastin again have been sort of discouraged. However, in patients who do not wish to have blood products, again, there is a place to try them out. There has been some literature that, especially in patients with myeloid malignancies, that like MDS, that this can increase the risk of myeloid transformation. These are the other thing that is available is recombinant human thrombopoietin, which can be used. There are some abstracts in ASH and in some of the ASCO meetings where they have shown that recombinant thrombopoietin, just like in the case of erythropoietin, have significantly improved platelet recovery and reduces the need for platelet transfusion in patients with AML and with lymphomas. And we have used recombinant thrombopoietin in a few of our patients. The problem is that you have to continue giving it for a long period of time, but in the short term where we have used it, it has helped in some of the patients. Luspatercept and other agents like imetelstat now have been licensed in patients with low-risk myelodysplastic syndrome. And patients with myelodysplastic syndrome, might require blood transfusions very frequently. And if the erythropoietin levels are less than 500, then we could give them something like, the erythropoietin stimulating agents. We have quite a few of them available. However, if the erythropoietin is more than 500, then the ESAs may not work, and therefore we can resort to drugs like luspatercept and more recently imetelstat. So again, I'm not going to go through this because they have been dealt with before. So especially in patients with myelodysplastic syndrome, the imetelstat, which is a telomerase inhibitor, is showing good results, especially in the low-grade or the low-risk myelodysplastic syndromes. Then we can also use the IMiDs, thalidomide or lenalidomide. We also use androgens, which can increase which can stimulate erythropoiesis, and hypomethylating agents. So there are quite a few agents available, especially for patients who need a very regular and a number of units every month, patients with myelodysplastic syndrome. Then finally, with these targeted therapies and the need for intensive chemotherapy is now fairly less, especially in conditions like AML, where I mentioned earlier, where intensive chemotherapy is very hard to take a patient through AML induction chemotherapy without some use of blood products. However, with the targeted therapies like venetoclax and azacitidine, now studies showing that the outcomes are as equal to intensive chemotherapy, and these patients can be treated more or less as outpatients, and the transfusion requirement is less. Things are becoming probably a little easier now. Also, treatment with Bruton tyrosine kinase inhibitors versus chemotherapy for the B-cell lymphomas, and CAR T cells versus auto stem cells for consolidation for conditions like diffuse large B-cell lymphoma are also becoming more feasible now. I'll stop there and just highlight some take-home messages. So managing hematological malignancies without transfusions can be very challenging. However, awareness of PBM strategies within teams managing this cohort of patients is very important. And with more targeted novel therapies being available, the concept of transfusion-free management of hematological malignancies is becoming more practicable. Thank you very much.
Thank you, Dr. Gunaratna. We actually met in Thailand, and I had asked Dr. Gunaratna if he could present for us today, and he was very happy to do it. So I'm very grateful. I know we changed the topics a few times, but thank you for being so gracious. Thank you. So we will be moving on to the Q&A session. So I would invite the panelists and also the speakers for Q&A. So my first question is for Carrie and Jennifer. So it says, could bloodless transplant strategies eventually influence standard ASCT protocols?
We think yes. I think there's we hear from even our standard patients who do accept blood products, we know that there are risks to accepting those. And we've shown that this is a safe approach. You think about the cost associated. So if you were to take cost into account, there really is not an increased cost in the collection or processing of cells, or in any of the medications that we're using are inexpensive. So that would be one reason. And we're showing that our outcomes are just the same, if not better in some cases. So
Yeah, there's not a difference. We haven't shown any difference in length of stay. As we showed, time to engraftment, how patients are doing and recovering, either really is identical when we compared, equal cohorts of 400 of our patients, 200 without blood products and 200 with, and really finding identical outcomes. So we definitely, I think there's a role to move in that direction.
Okay. And I do have a question from the audience for Carrie. It says, in the post-transplant period, is there any significant functional difference between Amicar and TXA? I ask because Amicar is very rarely used in the UK.
If you have an equivalent antifibrinolytic agent that you're using, there and you want to take costs into account, yes. You may see on our slides we do use oral TXA as an alternative, if IV access is a concern. So they're both effective.
Okay, and I have a question for Dr. Mandy. How do you balance patient autonomy with the risk of profound anemia and transfusion-free care?
How do I balance? Thank you for the good questions. I think it's really difficult. As you can see, the first case, I think I will provide all the information that is available. If the patient is asking for bloodless care, for example, like the first patient I provided to her. But at the same time, I think I'll still advise her that in terms of the response, like her case, that is not good. I still try my duty, as I said just now when I was giving the talk, to convince her to, because all of us know thalassemia major with transfusion, they actually will survive. But unfortunately, this patient has educated me, I would say, that bloodless care is really what she wants. And that message is really strong. That's why I actually presented her case today, thanks to her. In fact, I'm learning patient blood management from the patients. Yeah. Thank you.
Yes, I have one last question for you, Dr. Mandy. Do you believe gene therapy could eventually make transfusion independence achievable for most thalassemia patients?
I strongly will feel gene therapy is really curative because there's a lot of good data that's being shown in China as well as in India. Just now I was wanting to add on about the lentivirus. The secondary malignancy that was being shown initially from the first generation of the like the Bluebird technology I was saying, is not really being reproducible with the third generation now. As I think in America, they have Zynteglo as well as Beticel for the lentivirus gene additions. And for the China and even for India, Professor Alok Slavista, I think some of you will know him, that he has been using lentivirus technology for 15 years and he hasn't been seeing much cancer risk among his patients, as well as insertional mutagenesis, which is the theory risk. And for the gene, unfortunately, for the gene editing is really expensive. I think in terms of accessibility, I would still recommend my patient go for gene addition at this moment. As I said, it's 1/10 of the cost. And I hope that we are having plan in our country in the pipeline to actually make our own gene therapy so that can benefit like almost 10,000 of our patients in Malaysia. Thank you.
Thank you. And I have two questions for Dr. Gunaratna. Could targeted therapy significantly reduce transfusion needs in hematologic malignancies?
Yeah, I mean, that's a very good question. And I do believe that that is in fact true, because we know that with intensive chemotherapy that, not only is the patient in hospital, but sometimes due to things like, infections, fungal infections, systemic, very bad systemic infections, the risk of bleeding, significant bleeding is very real. So I do believe that targeted therapies will, there's the added benefit of targeted therapies is that the transfusion requirement could be minimized and better controlled than using intensive chemotherapy.
Okay, and then one last question. How do clinicians balance restrictive transfusion thresholds with patients' quality of life?
Yeah, I think as I think one of the previous speakers showed, quality of life, even transfusions can affect quality of life adversely. So it is not that, just because a patient has some sort of a symptom or there is a clinical indication to give transfusions, that's going to improve the quality of life. So I think it's very important to, explain things to the patient and say that, this is what the recommendations or the policy or the guidelines are, and then make an individualized decision together with the consultation with the patient and the family, and then decide, pointing out the fact that all these, whatever the transfusion is, whether it's a red cell, platelet, plasma, all of them can have even sometimes fatal reactions. So therefore, quality of life, I think we need to see in the sort of entirety of things, and not only just alleviating symptoms of the patient.
Okay, thank you all. Thank you. Amazing talks. We've learned so much. Without further ado, I will be introducing Bristol Scientific. There's a presentation from Bristol Scientific.
John Shidiak, who's supposed to make that presentation, just messaged me that unfortunately his laptop crashed and he's in transit. He's trying to get the hotel technicians to work on it. So I think we might have to move that presentation to maybe a Saturday to give him time to get his laptop back.
Okay, well,
So
if that's the
if
case,
you still have more questions that haven't been answered, you're free
okay.
to take them.
Okay. I do have, this is a comment. It says, just a comment about avoiding flossing. Bleeding from flossing occur due to gum inflammation, not because of flossing itself. I floss 3 times a day and never experience my gum bleeding. Gentle daily flossing is highly recommended for good dental and gum health.
I could
That's
just
such a good point. I think one note, since we do have a little time to talk about it, we found that one of our prerequisites for patients receiving care is to have a dental clearance. And understanding that, dental care in the United States is probably different than across the world, but that is one of our major reasons for delay, is that a patient might have some dental concerns that they need to have taken care of in advance of their anticipated prolonged period of neutropenia. And so the way that we describe to patients is we just want to make sure nothing is brewing there that could pop up during your transplant. So I think that is a great point about flossing, considering that we don't want anyone to start flossing in the hospital. If they have a consistent process for it in advance, wonderful. But yeah, dental care is definitely a concern of ours and of our patients, with both bleeding and infection.
Yeah, I think when we describe it to patients, it's sort of if you're flossing at home regularly, it's going to be fine to take a break for this couple of weeks, just because even gentle flossing can cause, sort of micro just irritation to the gums, and our mouths are already filled with bacteria on a regular basis as is, and just from the infection avoidance, standpoint, and especially, if you're sitting with your platelets at 5, we'd prefer to err on the cautious side and hold off for those couple of weeks.
Makes sense. I have a question. Is it advisable to request testing for data such as reticulocyte count, ferritin levels, iron saturation levels for stem cell patients? It appears that there is hesitancy to test for these with some clinicians.
There definitely is hesitancy, and a lot of that, we do a lot of education in and outside of our cell therapy program. So in even thinking about our women's health population and anemia and pregnancy, um, you know, Dr. Ford treats those patients, and sometimes we do have to urge them, urge the other clinicians to obtain those labs. But I think it just comes with education, and when they're under our care, we're drawing those labs judiciously and following them. And I think that goes back to when Jen was talking about our pre-treatment, knowing those way in advance so that we can act on them um, prior to transplant and really optimize their counts.
Thank you. And there's a question, may I ask whether you see the role of fibrinogen concentrate to address active bleeding and separately TPO RAS for significant thrombocytopenia? This is open.
Well, I'll speak for our center. We haven't, while we have those as tools, we have not used them yet. So I guess theoretically they could be used, but in practice we haven't seen that.
Thank you.
Well, I think, sorry, can I add on that?
Yes, go ahead.
I think fibrinogen concentrates has really good data, and I've used it quite a number of times in active bleedings. Certainly will encourage the use. And I think for the other one, I think it was talking about TPO, thrombopoietin agonist. Yeah, I think that's now Prof has shown quite good cases that we use those with thrombocytopenia due to chemotherapy. Yeah, we have experience, and we have even experience using for ITP, some of the patients with idiopathic thrombocytopenia purpura. Thank you.
Thank you. Do any of the panelists want to jump in and comment?
Please, can you check some questions that was dropped at the chat box? There are 2 questions at the chat box.
Do you mind reading them? Because there are a lot of things, yeah.
Abigail, go ahead and read the questions.
Let me look for them. Okay, one of it is that my husband was recently diagnosed with stage 1 non-Hodgkin lymphoma. We are interested in understanding both standard care and bloodless treatment options. What are the most important things he can do medically, nutritionally, and lifestyle-wise to help prevent progression and keep the disease as stable as possible, while also protecting his blood health and avoiding unnecessary transfusions if treatment becomes necessary? That's one of the questions.
So if I get it, if I heard correctly, this is about a patient who's been recently diagnosed with a lymphoma.
Stage
Yeah,
1.
non-Hodgkin lymphoma,
Right.
stage
Okay.
1.
Okay, so as you know, sometimes depending on the type of lymphoma, especially if it's a low-grade lymphoma, the patient may not even need treatment for a lymphoma if the patient does not fulfill the indications for treatment. But I think as the question was how we can optimize his general well-being and his nutritional status. So I think it's important that the physician looking after this patient needs to do some basic medical workup and investigations to see. I think there was some mention about doing a full blood count, maybe looking for iron levels and stuff like that, which are very easily attended to. So I think, especially in a condition where the patient may need specific treatment in the future, it'll be important to see whether there are any deficiencies, especially nutritional deficiencies, any other issues where there's enough time for those things to be attended and corrected.
Okay. The second question is from Herman. He's asking, can we use vitamin K when we have bleeding in the case of cancer and we haven't erythropoietin?
Right. So the question is about vitamin K in someone who's bleeding with cancer. But yes, vitamin K is something which is necessary for the synthesis of clotting factors. And in some situations, especially like say if the patient has involvement of the liver, then and there's sort of obstructive jaundice, or there's the patient has a condition where vitamin K absorption has been impaired, then giving vitamin K would be essential. But I'm not sure whether the question was, instead of, if you don't have was it thrombopoietin probably, or erythropoietin? Yeah. So the vitamin, vitamin K will not have an effect similar to that of erythropoietin, whereas erythropoietin will stimulate the red cell production. But if the patient is impending some sort of a clotting disorder, then of course vitamin K would help. I hope I understood the question and answered.
Yes, well answered.
Yeah.
We have one more question, and then that should end the Q&A. What effect does herbal teas have on patients with thrombocytopenia?
Should I take that as well? Yeah. So, herbal teas are, very, very common now, especially in our parts of the world. And it depends on what the composition of the herbal tea is that will have its effect. So, as was mentioned, I think by some of the speakers from Pennsylvania, I saw that in the list it says garlic and ginger and so on. Now, these are very well established that, for example, garlic has an antiplatelet effect. So if you drink or ingest large amounts of garlic, it is like someone, taking an aspirin or a clopidogrel. And if your herbal tea or concoction has lots of garlic, it would be like, someone with thrombocytopenia can actually have a bleeding tendency. We've had patients who, come with bleeding, and we do lots of investigations, but we cannot find why the patient is actually having bleeding. And then when we sit down and take a closer, a closer history, have a closer discussion with the patient, then it comes to light that they have been on this herbal medicines for a long time, because of its effect, of its antiplatelet effect. We know that in patients with cardiovascular risk factors, garlic and things like cinnamon have shown to have some improvement in cardiovascular risk. So patients tend to take these quite, liberally, without very much control. So that can cause that. And then, as I mentioned earlier, concentrated tea, we know can interfere with the absorption of iron. And as I mentioned earlier, we do have, it's quite fashionable in this part of the world to have green tea after dinner, and especially in this part of the world where our natural diets don't have so much of heme iron. It's sort of rice-based diets with not much of red meat or red fish. It can compromise the iron stores if patients take these strong teas together with their meals for a long time. So it really depends on what the concoction has, or what it contains, which can cause mostly good effects, but sometimes adverse effects as well.
Thank you very much. Thank you so much for all the presentations. We're very grateful. And then the extra time for more questions. So I will preview tomorrow's program. Tomorrow, we will have talks, the critical role of hematologists in bloodless medicine. That will be presented by Dr. Alfoneme. Clotting disorders, Doing Without the Yellow by Dr. Majid. Heroes of Bloodless Medicine, Denton Cooley. That will be presented by Sherry. And then a panel discussion by Adrian. So this brings an end to our program. I would like to ask the panelists to turn on their cameras so we can take pictures. And thank you all for coming, and we hope to see you tomorrow. Dr. Osoro, can you please take the pictures? Thank you.
Okay, let me see if I'm a good photographer. But you can also please screenshot from there. Thank you.
Okay.
When you're ready, please tell us to smile.
Okay, smile.
Yeah.
Hey, I'm done. Thank you.
Okay,
Thank you,
I'm done
everyone.
too. Thank you, everybody.
Thank you all.
Thanks, Vixen.
Thank
For
you.
coming.
Thank you.
Thank
Wonderful
you,
program.
everybody. Thank you. Good night.
Sarah, you're owing us some music.
Yeah.
She needs to set up the band.
So